I don't see Dr. Cannon on, so I will be chairing if just in case until Dr. Cannon is joining us later. So good morning and thank you everyone for attending our DURB board meetings. A few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. For DURB board member, please reserve your question until the end of the presentation or ask in the Google Meet chat. For public comment, if you would like to provide public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not member of the DURB board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. And the first item of our meeting today is the approval of the minute.
I move to approve.
Thank you, Dr. Turner. Do we have a second?
I'll second.
Just a quick comment. There was a misspelling of Bella Gonzalez's name, and so you might suggest that be corrected before approval.
There was also, I just noticed, a misspelling of my name.
Thank you, Susan.
Thank you, Dr. Siegfried. Okay. Do we have a motion to approve the minutes pending those correction? Any others?
So moved.
Thank you, Dr. Weinstein. Do we have a second?
Second.
Thank you, Dr. Turner. All in favor?
Aye.
Thank you. Any opposed? Great. Motion passed for approving the minute pending the corrections of those items. The second item of today is housekeeping. We have the new pharmacy director with us today, Dr. Sapide. Sapide, would you like to give a minute to introduce yourself?
Good morning. Can you hear me?
Yes.
Yes, thank you.
Perfect. Sorry, I apologize that I'm not able to be on the video to this time. But I just wanted to thank you guys for allowing me to introduce myself. My name is Sapide Dairi. I am a pharmacist, and I'm new to role as a pharmacy director for Medicaid. I have a background of different subjects such as computer science, math, but I became pharmacist and I work as a pharmacist since 2009. I worked for Walmart for over 18 years almost, and I'm really excited to have this chance to be exposed to different environment as a pharmacy settings, and it seems like it's going to be a great opportunity for me to help our community, and I'm so grateful to have this chance.
Thank you, Sapide. Would you like to give an additional update on our situation?
Yes. So I noticed that we did not have this meeting. It's been a month, so I don't know if you guys were aware of the opportunity we had to deal with during this past month with our Change Health, which is the vendor for processing claims. In February 12th, due to the cyber attack, the system went down, and majority of the claims throughout the nation was not able to go through, and that impacted also Medicaid. So due to this situation, from February 12th until finally March 12th, which is, was it Wednesday, Thursday? It was a couple days ago, that none of the claims were able to go through for Medicaid. So after 3 weeks of Change Healthcare network and system outage, now pharmacies are once again able to bill Utah Medicaid directly and get claim paid for their member prescriptions. The launch of the system is in a new environment, and it brings our Medicaid close to fully function. We are not fully function right now. We cannot do the prior authorization and some of the copays. So they're a work in progress. We are wanting to make sure that our patient, they are getting their prescriptions. So the system right now is bypassing the normal pharmacy edit for those situations that the claims are not able to go through for copays and prior authorizations. We place this bypass to make sure that it's easier for a member to get their prescription and pharmacy to get paid. And then let's see what else. I think that's where we are right now. It seems like during these past 2 days, all the claims that they are going through, we see the claims and we are able to process those. Because of a lot of work that pharmacy, they are also going to put to process these, we are going to add additional dispensing fee for the pharmacy to be able to do that. I think that's all. I just wanted to give that information to you guys. So from February 21st through March 12th. And right now, almost a month. Oh. And again, right now, though, it's not fully functioned. We do not have the actual date when we are going to be fully functioned. We continue to work closely with the Change Health until the full resolution of operation and functionality are completed.
Thank you. Oh, sorry.
Go ahead. That's all I have for now.
That's okay, Sapita. I was just going to thank you. And I was also going to apologize because I'm realizing that this is your first time joining DUR. So I should have introduced you, but thank you so much for introducing yourself. And thank you for that update. I think at the end you did say that in the beginning you were saying February 12th, but it was February 21st. Yes. So
March
you're totally
12th,
right.
Yes.
Yes. It was a challenging time, and thank you for that high level overview. I just wanted to acknowledge that we have Miles Rooney on the call. He's our Change Healthcare representative. He's our point person, and he worked so hard to get us back online as fast as possible. So we really appreciate his work, and we're glad to be able to process claims again. So thank you.
Thank you.
Thank you, Yoon and Sapide.
Oh, and sorry, Noon. Miles, you did an amazing job, but I also want to say that our pharmacy team worked so hard the last, several weeks trying to make sure that things came back online well. And I also want to acknowledge the work that the team did, which they worked after hours, they worked weekends. It was rough, but luckily I think those days are behind us.
Exactly, and piggyback on you, what you were saying, our team did amazing. And Miles, you were a really great support. I really wanted to appreciate everybody that were involved in this, all hands down. Like everybody were working so hard, including weekend and long hours, and make this happen. Thank you, Yoon. Thanks, everyone.
Thank you, Yoon. Thank you, Sapide. Next item on the agenda will be the gene therapy for sickle cell disease presented by the University of Utah, DRC.
Okay. Hopefully everyone can see those slides. Good morning. Today I will be reviewing recently approved gene therapies for sickle cell disease, levotibeglogene autotemcel and exagamlogene autotemcel, which for simplicity I will refer to as Lovocel and Exocel respectively. Sickle cell disease, abbreviated SCD, is a rare hematological genetic disorder that originates from a singular point mutation in the gene responsible for hemoglobin A, the predominant hemoglobin type in adults. As a result of the mutation, sickle hemoglobin, or HbS, is formed, which distorts erythrocytes into a rigid, sickle-shaped morphology, leading to tissue ischemia, vaso-occlusion, organ damage, and premature hemolysis. Vaso-occlusive crises, abbreviated VOCs, also referred to as vaso-occlusive events or episodes, or VOEs, are the predominant clinical manifestation of SCD and a major contributor of SCD-related morbidity and hospitalization. Recurrent VOCs generally result in severe disabilities and/or premature mortality. The most severe manifestations of SCD are typically observed in patients with genotypes of HBSS or HBS beta 0 thalassemia. Both of these genotypes are commonly referred to as sickle cell anemia. Conventional treatment for SCD includes hydroxyurea, which is the mainstay of SCD treatment, newer disease-modifying agents, red blood cell transfusions, and supportive care. While these treatments may improve disease status, they are not curative and often fail to completely eliminate SCD-related complications. Prior to the approval of lovo-cel and exa-cel, allogeneic hematopoietic stem cell transplantation, or HSCT, was the only potential curative option for SCD. Autologous HSCT using gene therapy is an alternative, potentially curative option for SCD that circumvents issues with donor scarcity and certain risks with allogeneic HSCT, including graft versus host disease. Lovo-cel and exa-cel were approved by the U.S. Food and Drug Administration in December 2023 as the first gene therapies for patients with SCD. Both products are indicated for patients aged 12 years and older. Lovo-cel is approved for patients with a history of VOEs, and exa-cel is approved for patients who experience recurrent VOCs. Exa-cel is also approved for transfusion-dependent beta thalassemia. However, this presentation and review were focused on the indication for SCD only. Lovo-cel does have a limitation of use in patients with alpha thalassemia trait who may experience anemia accompanied by erythroid dysplasia after undergoing treatment with lovo-cel, potentially necessitating ongoing red blood cell transfusions. Lovo-cel and exa-cel are genetically modified hematopoietic stem cell products that express healthy hemoglobin molecules and thus non-sickled erythrocytes. These products are derived from the patient's own hematopoietic stem cells, which are genetically modified ex vivo and then administered as a one-time intravenous infusion. Lovo-cel production entails adding a healthy beta globulin gene variant into the stem cells using a lentiviral vector to produce a form of functional hemoglobin A. Whereas exa-cel production involves editing the expression of BCL11A in the stem cells using clustered regulatory interspaced short palindromic repeats, or CRISPR, and Cas9 technology to increase production of endogenous fetal hemoglobin. Lovo-cel or exa-cel can only be administered after necessary patient preparation procedures have been performed, as outlined on the next slide. Patient preparation procedures include confirming the patient is a suitable candidate for autologous HSCT, mobilizing hematopoietic stem cells into the blood, apophoresis or collecting hematopoietic stem cells from the blood, and myeloablative conditioning with chemotherapy to deplete existing HbS-producing hematopoietic stem cells from the bone marrow. Some patients may need to undergo several mobilization apophoresis cycles to acquire the minimum quantity of hematopoietic stem cells needed for genetic modification and dosage. A reserve harvest is also collected and kept unmodified as a contingency in the event the manufactured product is compromised or engraftment failure occurs. Myeloablative conditioning should only commence after lovo-cel or exa-cel has been received at the treatment center and the reserve is available if needed. Usually, patients undergo myeloablative conditioning with busulfan administered intravenously via a central venous line for 4 consecutive days. After completing myeloablative conditioning, a minimum 48-hour washout period is required before initiating the lovo-cel or exa-cel infusion. Although the duration of these procedures varies, patients should expect to spend several days at the hospital for stem cell collection and several weeks admitted inpatient for myeloablative conditioning, infusion treatment, and recovery. Due to the complexity of the multifaceted treatment process, lovo-cel and exa-cel are exclusively accessible and administered at authorized or qualified treatment centers, which have been vetted by the drug sponsor. Currently, there are no qualified or authorized treatment centers for lovo-cel or exa-cel located in Utah. The closest centers in relation to our state are in California or Arizona, the latter being for lovo-cel only. Due to the potential for interactions, prescribing information for lovo-cel and exa-cel recommend discontinuing certain agents, including hydroxyurea, Lexator, crenelizumab, and L-glutamine in the setting of stem cell mobilization and collection and myeloablative conditioning. The table on this slide provides an overview of the specific recommended time points for discontinuation. Notably, patients should continue routine red blood cell transfusions leading up to apheresis and myeloablative conditioning to maintain hemoglobin levels within the recommended target range of less than or equal to 11 or 12 grams per deciliter, depending on the product. Clinical practice guidelines predate FDA approval of lovo-cel and exa-cel. Therefore, they do not provide recommendations regarding their use or the use of gene therapies. However, the American Society of Hematology, or ASH guideline for allogeneic HSCT, published in 2021, described that patients with SCDs should generally be optimized on the standard of care, including hydroxyurea or SCD disease-modifying agents, before considering HSCT. Possible exemptions to delaying HSCT may be made for patients who have frequent pain, have recurrent episodes of acute chest syndrome, abbreviated ACS, or have an abnormal transcranial Doppler ultrasound or history of overt stroke. Experts tend to reserve gene therapy for patients who are eligible for allogeneic HSCT but who lack a matched sibling donor. Because sibling-matched HSCT has robust, long-standing supportive evidence within the SCD population, most clinicians would consider it first line before gene therapy, which at present has relatively limited evidence, especially regarding long-term toxicities and durability. Notably, gene therapy was not yet approved at the time of the expert opinion publications. Approvals may influence future expert opinion on gene therapy eligibility. Based on evidence from matched sibling HSCT, the 2021 ASH guidelines suggest eligible patients should undergo transplantation at an earlier age before irreversible SCD-related complications occur and to maximize the benefit of preserving organ function. Theoretically, this recommendation may also be applicable to gene therapy. Lovo-cel and exa-cel have been or are currently being evaluated for SCD in 4 clinical trials that have results. Of these, 3 trials pertain to lovo-cel and 1 trial is for exa-cel. FDA approval of lovo-cel was primarily based on the HGB-206 trial, supported by evidence from HGB-205 and HGB-210. Each trial was a single-arm, open-label study with a follow-up duration of 2 years for the primary outcome. All these trials are ongoing except for HGB-205, which is completed with published results in a peer-reviewed journal. As of the latest interim analysis, HGB-205, HGB-206, and HGB-210 included 3 participants, 36 participants, and 2 participants, respectively. In the exa-cel trial, CLIMB 121 included 44 participants. There are ongoing long-term follow-up studies for these therapies, LFT 307 for lovo-cel and CLIMB 131 for exa-cel. Results discussed on the subsequent slides account for the original trial results and long-term follow-up observations if available. This table shows key inclusion criteria for each study. Although age criteria for study inclusion ranged from 2 years up to 50 years, the safety and efficacy of lovo-cel and exa-cel has not been established in pediatric patients younger than 12 years of age or older adults. Each trial enrolled participants with severe SCD, usually defined as having a particular genotype associated with a severe phenotype. Most trials require participants to be candidates for allogeneic HSC but lack a matched related donor, and excluded those who previously received an allogeneic transplant. Each lovo-cel clinical trial required participants to have inadequate control of VOEs or VOCs while taking hydroxyurea. The exa-cel clinical trial did not specify such criterion for study inclusion, but nonetheless required participants to experience recurrent VOEs despite appropriate supportive care. The number and definition of VOCs or VOEs varied between trials, but generally included participants who had at least 4 VOCs or VOEs in a 2-year period. Among the lovo-cel clinical trials, HGB-210 has a unique exclusion criterion of chromosomal or genetic abnormalities that could increase the participant's risk of developing myeloid dysplastic syndrome or acute myeloid leukemia, as determined by the investigator. Additionally, those with genetic mutations causing inactivation of 2 or more alpha globulin genes were excluded from HGB-210, most likely because after treatment with lovo-cel in study HGB-206, 2 participants who had 2 alpha globulin gene deletions, also known as alpha thalassemia trait, developed persistent anemia. It was determined that the anemia was likely attributable to alpha thalassemia trait. In the lovo-cel clinical trial HGB-205, all participants achieved successful engraftment, but only 1 of 3 was SCD symptom-free and did not require pain medications, red blood cell transfusions, or hydroxyurea for SCD-related complications after engraftment. Another participant was VOC-free until an event was precipitated by gastroenteritis at month 30 after receiving lovo-cel. The VOC event resolved after symptomatic management and hospitalization, and since then the participant has remained symptom-free as of August 2020. Overall, both of the aforementioned patients showed stable HbA-T87Q levels up to 36 months after receiving the lovo-cel infusion, with concentrations ranging from 28 to 48% of total hemoglobin, and decreased hemolysis markers without receiving chronic red blood cell transfusions. The remaining participant experienced recurrent episodes of VOCs and ACS, and as a result restarted red blood cell transfusions at month 6 and hydroxyurea at month 13 following the lovo-cel infusion. Regarding the safety profile, no adverse events were deemed to be directly related to lovo-cel. Of the 32 HGB-206 trial participants who met the eligibility criteria of greater than or equal to 4 severe VOEs in the 24 months preceding enrollment, 88% were VOE-free and 94% experienced complete resolution of severe VOEs between 6 to 18 months after receiving lovo-cel. After 18 months to last follow-up assessment at a median of 38 months, 4 of 28 participants who had been VOE-free eventually experienced an event. Among all 36 treated participants, 31 achieved and maintained a globulin response for a continuous period of at least 6 months after receiving lovo-cel. 73% of treated participants experienced at least 1 serious adverse event, with most events attributed to myeloablative conditioning or SCD. The most common adverse events, grade 3 or higher from day 1 up to month 24 after receiving lovo-cel, were stomatitis, thrombocytopenia, neutropenia, febrile neutropenia, anemia, and leukopenia. Interim results from HGB-210 as of August 2020, excuse me, showed complete resolution of VOEs, including severe VOEs, up to 15 months after receiving lovo-cel among 2 participants. Additionally, HbA-T87Q levels stabilized for around 6 months up to 15 months following the infusion in both treated participants. Most recent interim results as of February 2023, also including individuals from HGB-206, showed that 94% of participants had severe VOEs completely eliminated between 6 to 18 months after lovo-cel treatment, and approximately 88% of participants remained VOE-free for a median of 35.8 months. Participants who had VOEs at any point post-treatment through long-term follow-up demonstrated a substantial decrease in both the frequency and severity of VOEs compared to pretreatment with lovo-cel. Most adverse events were ascribed to either SCD or the myeloablative conditioning procedure. As of the latest interim analysis for the exa-cel clinical trial, about 94% of evaluable Climb 121 participants had complete resolution of severe VOCs for greater than or equal to 12 months, starting 60 days after the most recent red blood cell transfusion, with a mean duration of 22.2 months. One patient who had initially achieved the primary outcome eventually experienced a severe VOC at month 22. The participant has fully recovered and has been VOC-free since the event. Among all treated participants, increases in fetal hemoglobin levels were observed by month 6, with mean fetal hemoglobin proportions above 40% maintained up to month 24, which is considered to be above the clinically meaningful threshold of 30%. The safety profile of exa-cel was generally consistent with adverse events related to HSCT or myeloablative conditioning. The most common grade 3 or 4 adverse events between day 1 and month 24 were mucositis, neutropenia, thrombocytopenia, leukopenia, and anemia. Excuse me. Lovo-cel and exa-cel do not have any labeled contraindications. Both products carry warnings for potential hypersensitivity reactions, delayed platelet engraftment, and neutrophil engraftment failure. In addition, lovo-cel has a black box warning for hematologic malignancy, along with a unique warning for insertional oncogenesis. Exa-cel carries a warning for the potential risk of off-target genome editing. Furthermore, exa-cel prescribing information advises avoiding use in patients who have received either an allogeneic or autologous HSCT, as it has not been studied in this population. Prescribing information for lovo-cel does not address its use among patients who have previously received an HSCT. Considerations for prior authorization criteria are summarized on the next 2 slides, and additional considerations are provided starting on page 25 of the report. Patients should be required to meet the FDA indications for these products. Lovo-cel and exa-cel can be reserved for patients who are at least 12 years of age and have a confirmed diagnosis of SCD. Since exa-cel is also approved for the treatment of transfusion-dependent beta thalassemia, the prior authorization could incorporate this indication as well. The remaining points are with respect to request use for the treatment of SCD only. To be consistent with product labeling, patients receiving lovo-cel must have a history of VOEs, and for exa-cel must experience recurrent VOCs. Note that most clinical trials required patients to meet criteria for a specific threshold and time frame for VOCs or VOEs. However, these criteria may be arbitrary and may not account for factors such as patients managing VOCs or VOEs at home, so it may be reasonable to not require any specific VOC or VOE severity thresholds. It may be reasonable to require that patients requesting lovo-cel do not have co-occurring alpha thalassemia trait or 2 alpha globulin gene deletions due to the potential risk for anemia. Moreover, lovo-cel has not been studied in patients with more than 2 alpha globulin gene deletions. In alignment with clinical trial eligibility criteria and expert opinion, may consider reserving these therapies for patients who are eligible for HSCT, but who do not have an HLA-matched sibling allogeneic HSCT donor. With respect to SCD medications, consider requiring provider attestation or clinical documentation that the patient has tried and failed, is intolerant, or has a contraindication to hydroxyurea and or at least one other disease-modifying agent. As a reminder, clinical trials for lovo-cel required participants to previously experience hydroxyurea failure or intolerance. L-glutamine, Veloxator, and crenilizumab became available after most of the reviewed clinical trials for lovo-cel and exa-cel were started. Prescribing of these transplant products may be restricted to hematologists only, given the complexity of the treatment process and the advanced training required to perform HSCT. May also consider requiring that both products be administered in accordance with the FDA-approved labeling as a one-time intravenous infusion with a minimum recommended dose of 3 times 10 to the 6 CD34 positive cells per kilogram. Patients should understand that not everyone will experience a cure or adequate response from these gene therapies, and thus may need to restart traditional SCD treatments intermittently or permanently, including trial of other SCD disease-modifying agents if the gene therapy is unsuccessful or residual SCD symptoms persist. May consider requiring provider attestation that the patient does not have a history of or active hematologic malignancy, and specifically for lovo-cel that the patient does not have high-risk mutations for developing myelodysplastic syndrome or acute myeloid leukemia. Some additional considerations include requiring that the patient is not positive for HIV or hepatitis B or C, has adequate bone marrow function, and has not received a prior HSCT, and ensuring that the provider has discussed with the patient the potential risks of neutrophil and platelet engraftment failure, pregnancy status monitoring throughout the treatment process, and adverse effects from necessary patient preparation procedures. This concludes the presentation. Please let me know if you have any questions.
Thank you, Dr. Lulu. Is there any questions for Dr. Lulu from the board regarding the presentation? Now we can move on to the next item is the public comment from the Vertex Pharmaceutical.
Hello, I think that's me, Chad Duncan.
Hello, you will have 3 minutes for the public comment, and Brian will, okay, thank you. We'll keep track of it.
Thank you very much. Hello, my name's Chad Duncan. I'm a PharmD and part of our field health economics and outcomes research team here at Vertex Pharmaceuticals. And thank you, Dr. Lulu, for a very thorough review there of the 2 products here that you're reviewing today for sickle cell disease. Casgevy is a modified autologous CD34 hematopoietic stem cell gene therapy. It's indicated for the patients 12 and older with sickle cell disease with recurrent vaso-occlusive crises and transfusion-dependent beta thalassemia. Today, my talk will really just discuss the sickle cell disease indication only. And so Casgevy is an ex vivo non-viral CRISPR-Cas9 gene-edited therapy that reduces the BCL11A protein expression in the erythroid lineage cells and thus leads to an increase in fetal hemoglobin protein production. Increased fetal hemoglobin expression has been shown in natural history studies to reduce or eliminate symptoms associated with sickle cell disease. A complete list of warnings and precautions associated with Casgevy has previously been shared and can be found in the Casgevy prescribing information. And the efficacy and safety of Casgevy was studied in the CLIMB Sickle Cell Disease 121 single-arm, open-label, multi-site, single-dose study. All information here and after is based on the interim analysis based on data from June of 2023 of the 31 patients eligible for the primary efficacy analysis and the 44 patients who had been administered Casgevy. Patients infused with Casgevy in the primary efficacy analysis of 31 patients had a mean of 3.5 annualized severe VOCs with a range of 2 to 18.5, and 2 hospitalizations due to severe VOCs in the 2 years prior to the study enrollment with a range of 0.5 to 8.5 hospitalizations. At the time of the interim analysis, a total of 29 of the 31 patients, or 93.5%, who were efficacy evaluable, achieved the primary efficacy endpoint of freedom from severe VOCs for at least 12 months. And of the 31 patients evaluable for this analysis, 1 patient was not evaluable for the key secondary endpoint, a proportion of patients not requiring a hospitalization due to the severe VOCs for at least 12 months. All of the other patients, the 30 patients, achieved that hospitalization-free endpoint. Following Casgevy infusion, there were early increases in total hemoglobin and HbF levels, or fetal hemoglobin, that sustained thereafter, along with pancellular expression of fetal hemoglobin. Patients also reported clinically and meaningful improvements in quality of life, transplant-related measures, and the Casgevy safety profile was generally consistent with that expected of the myeloablative conditioning agent of busulfan or a hematopoietic stem cell transplant. A Markov economic model was utilized to project the lifetime costs and outcomes of individuals with sickle cell disease with recurrent VOCs treated with Casgevy compared to standard care, which included hydroxyurea and red blood cell transfusions. And all results presented hereafter are based on projections from the economic model, which is based on clinical trial data and some modeling and some assumptions. The results may not be fully
That's
generalized.
fine. Thank you.
Thank you.
Thank you for your comment. Any other
Yeah.
questions?
Any questions?
Any question? Doesn't look like it. All right, we can move on to the proposed criteria. The first one will be for Casgevy. As usual, these criteria has been shared with the ACO for the awareness and feedback, and this has been incorporated into the criteria as well. Criteria for Casgevy XSL. Criteria for approval, all of the following criteria must be met. The patient is at least 12 years of age. The medication is prescribed by a hematologist that is specialized in sickle cell disease. The patient has confirmed diagnosis of one of the following: either the sickle cell disease with recurrent vaso-occlusive crisis, defined as the history of at least 2 VOC annually within the past 2 years, or the patient has diagnosis of transfusion-dependent beta thalassemia. Defined as the patient have a history of requiring at least 100 ml per kilogram per year or 10 units per year of red blood cell transfusion in the past 2 years. The patient is not seropositive for HIV, Hep B, or Hep C virus. The patient has not received prior treatment with any gene therapy for sickle cell disease or beta thalassemia and is not being considered for treatment with any other gene therapy for sickle cell disease or beta thalassemia. The patient has not had any previous HSTC, hematopoietic stem cell transplant. The provider attests to the following: that the confirmation that autologous hematopoietic stem cell transplantation is appropriate for the patient. The patient does not have an available or willing HLA match sibling allogenic donor. Infectious disease screening will be performed in accordance with the clinical guidelines prior to cell collection for manufacturing. Antiretroviral medication will be discontinued at least 1 month prior to mobilization and until all cycle of apheresis are complete. Erythropoietin and hydroxyurea and other disease-modifying agents will be discontinued at least 2 months prior to mobilization and 2 days prior to conditioning. Iron chelation will be discontinued at least 7 days prior to mobilization and conditioning. The patient have tried and failed or intolerant to or has contraindication to hydroxyurea for at least 4 months or other disease-modifying pharmacologic agent. Initial authorization, 1-time single dose only. I just noticed that we don't need the reauth criteria because this is only 1-time authorization only.
Even for the last bullet related to prior treatment, do you want the 4 months, at least 4 months, to be after both treatments or just after hydroxyurea?
It will be, for now, it's only after hydroxyurea.
The others are just for an indeterminate amount of time?
The others, yeah, undetermined amount of time for the others criteria.
Okay, thank you.
Or if the board have others recommendation and suggestion for that criteria.
I had a question too about that second to last bullet that starts erythropoietin, because I think just the way it's worded is maybe needs to be adjusted. Where you say will be discontinued 2 months prior to mobilization and 2 days prior to conditioning. If that's specific to specific agents, what the timing is, or we just want to make, condense that language to say, timing whatever that is. If that's how the package insert reads, that's a little confusing.
You're right. Let me
I'm
double
not sure.
check.
I'm not sure exactly how to fix it, but I think the wording's not precise. I'm not sure if there was a slide, Monet, that had that on there, or something we can pull up, or I'll leave it to others who have better detailed knowledge there.
Yeah, give me 1 second to get that slide pulled up here. So I did have a slide on this. Here we go. And then I was just also looking into it because I wasn't sure about the 2 days before my ablative conditioning, because I was under the impression it would be at least 2 months, but I guess it could be depending on that on the agent. Because here I list mainly the ones used for sickle cell disease, agents, so I don't think it includes erythropoietin.
Thank you for that. I will take that back and take a look at it again. Chad, do you have a comment?
Just one comment. Our label and kind of clinical studies in around the HIV and the hepatitis is around active infections, not just if you are positive for those viruses. And I don't know if you would reconsider looking into that area as well as part of the label. In the label, and it doesn't really reflect around the hydroxyurea use or the other agents as well. It's really based upon the VOCs that patients are experiencing. So that's just 2 comments that I would have about the criteria that you're suggesting about the the infections being active with, you could have those viruses and be treated and no longer have active infections. Thank you.
Try it. We will take a look again at these criterias right here to making sure that it's according to the package insert. Any others, questions, comment on this criteria, on this PA? Yes, Dr. Smith.
Do we want to add something about pregnancy testing, prevention of pregnancy?
How the board feel about that one?
I recall there was a general statement about counseling patients regarding the risks, which included pregnancy and other risks that may be associated with the treatment. I think we make an assumption that that's in a discussion. So I don't know if that needs to be included or not. But if it does, then we should have all of those in there. Something about risk discussion, if we want to include that, then whatever is specific to this might be a bullet.
We
Yeah,
can-
I kind of like that idea. Maybe under the provider attests to the following, like something about a discussion of risk benefit, pregnancy and otherwise.
Would that be okay with the board? Discussion about the risk benefit, including reproductive consultation with the patient.
Maybe risk benefit of the therapy. Because it's also
I
pregnancy.
like that you broadened it.
Yeah, it's also pregnancy preservation or fertility preservation. That's part of that discussion too.
Right, and might also apply to males.
Yep. And teratogenicity.
Do we need a motion?
Yes, and then do we have a motion to approve the PAS mention?
I think it was Dr. Smith who was interested in adding teratogenicity to the last sub bullet. I wonder if it can just say discussion with patient about the risk benefit of the therapy, including fertility preservation and teratogenicity.
Yeah, that sounds good.
Do we have a motion?
So moved.
Thank you, Dr. Smith. Do we have a second?
I would second with that notation that we have the one bullet that would be reviewed for any necessary adjustment to the language for clarity.
Thank you, Dr. Weinstein.
Agree.
All in favor?
Aye.
Aye.
Thank you. Any opposed? Great. Motion passed to for CASEVI PA, bending the review of this criteria. The next one is the Lyfgenia. This is a proposal for the criteria for Lyfgenia. All of the following criteria must be met. The medication is prescribed by or a hematologist that is specialized in sickle cell disease. The patient have a diagnosis of sickle cell disease. The patient have a documented history of vaso-occlusive event, defined as a history of at least 4 VOE within the past 2 years. The patient is at least 12 years of age. The patient is not seropositive for HIV, Hep B, and Hep C. The patient has not received prior treatment with any gene therapy for sickle cell disease or being considered for treatment with any other gene therapy for sickle cell disease. The patient has not had any previous HSCT. The provider attests to the following: confirmation that autologous hematopoietic stem cell transplantation is appropriate for the patient. The patient does not have an available willing HLA mass sibling allogenic donor. Perform screening for infectious disease in accordance with clinical guidelines before collection of cells for manufacturing. Discontinue antiretroviral medication at least 1 month prior to mobilization and until all cycle of apheresis are complete. Discontinue erythropoietin, hydroxyurea, and other disease-modifying agent at least 2 months prior to mobilization and 2 days prior to conditioning. Discontinue iron chelation at least 7 days prior to mobilization and conditioning. The patient have tried and failed or intolerant or contraindicated to hydroxyurea for at least 4 months or one other disease-modifying pharmacologic agent. Similar to the other one, in only one authorization is allowed, no reauth, and we also included the box warning for Lyfgenia as hematologic malignancy has occurred in patients treated with Lyfgenia. Recommend to monitoring patients closely for evidence of malignancy through complete blood count as at least every 6 months and through integration site analysis at 6 and 12 months and as warranted. Any discussion related to Lyfgenia?
Just in the first bullet, the medication is prescribed by, if that is specialized, not specializes.
Thank you. Yes, Dr. Lula?
Yeah, I just had a minor point that I wanted to point out under that the patient's not seropositive for HIV, hepatitis B and C. Specifically in the package insert, it doesn't mention about hepatitis B or C. I think that was strictly with Exocel, but it does still mention HIV and, of course, appropriate screening for any diseases prior to cell collection.
Thank you for that. Yeah. Dr. Smith?
Can we copy and paste over the same bullet point about pregnancy and teratogenicity?
Yes. We want to know that even though the package insert doesn't mention Hep B and Hep C for Lyfgenia, we think it should be also included for active if patient have active infections for those. They shouldn't be receiving the gene therapy unless the board feel indifferent or unless the board thinks different than that.
So I have a question about the seropositivity and infection status, and it piggybacks onto the comment from our public representative on the previous discussion. Is the contraindication to the therapy for seropositivity, or is it for an active infection status? I would think that there might be many many disease conditions that would prevent this therapy from going forward, including active infections. But I'm not, again, educated enough to know, is it the seropositivity, particularly for these viruses that would prevent therapy, or is it the active infection status, and how that would be distinguished clinically at the time of considering the therapy? So are we saying here that we don't want, we want to broaden the criteria, so we're minimizing risk for patients who might have other infectious diseases? Again, that I would think the contraindications or the relative contraindications would have been assessed by the clinical team before they would consider treatment, and there's probably a very long list of those. So in short, I'm not sure that I understand the seropositivity criterion relative to the status of the patient having an active infection, if that's what we intend here.
Yes, per the practice insert, it stated that the negative serology test for HIV is necessary prior to apheresis. Patient with positive test for HIV will not be accepted for Lyfgenia treatment.
And we're adding the hepatitis viruses similarly. Mhm.
To the CASEVI criteria.
Mhm, mhm.
Any other discussions related to Lyfgenia? Yes, Jet.
Yeah, just one comment about this under the provider attest the following. And both of these, I'm not familiar with this label as well, but they do state the patient does not have an available and willing HLA matched sibling allogeneic donor. So only about 20% of the patients have that type of match. Available and willing is something else. But, even what Dr. Lulu mentioned, the expert opinion, that was prior to these drugs or these treatments being available. And so this is, to me, this criteria suggesting that if you do have that, you're not eligible for one of these two treatments, which I would think that may be better for the treatment team and the physician team, the hematology team to make that, whether they should go through hematopoietic stem cell or, go through that treatment versus one of these two treatments. And so I just wanted to mention that to the committee. And one thing with Casgevy, we have not seen any graft versus host disease or graft rejection and those failures with Casgevy. And so that is a risk of having a hematopoietic stem cell transplant. I just wanted to bring that up to the committee about that criteria. Thank you.
Thank you. Yes, Dr. Lulu?
Yeah, I did just also want to point out, similar to the XSL prior auth, that the discontinuation of, the agency I've listed could vary between, the myeloablative conditioning and the mobilization process. So
Thank you. I will double check on that, this criteria. Any other discussions, questions from the board? Do we have a motion?
I'm still thinking a little bit about the last comment related to the HLA matched sibling allogeneic donor, and if there's any modifications we can make to that bullet to make it more of a discussion rather than an absolute.
Me too, Dr. Hoffman. Is that for consideration, or are we're making that a step requirement, the way we have it worded in these?
Could it be that you make it a discussion about risk benefit of allogeneic transplant versus
I
gene
mean, it could,
therapies?
the patient is not a suitable candidate
Mm.
for, and then that becomes more of the provider discretion.
Mm-hmm.
I like that because there's so many things involved in, it's not only that there's the possibility of it, because that would be the necessary condition, but that's not always sufficient. Right?
Right.
So I like Dr. Hoffman's wording. Not a suitable candidate for. That's how you put it?
Yeah, the patient is not a suitable candidate for HLA. And then I guess I would propose we also make the change on the other PA.
Yeah.
Agreed.
Noon, can you just add stem cell transplant after the word allogeneic?
Yes.
With that change on this one, I would move to approve this as currently written.
Thank you, Dr. Hoffman. Do we have a second?
I would second with the same comment on that, just language on the discontinuation so that it's clarified accordingly.
Thank you, Dr. Weinstein. All in favor?
Aye.
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 Any opposed? All right, the motion passed for Lyfgenia pending the modification on the language on this one. And the next PA criteria we have is for Adakivio, represented by Stepford. Thank you.
Noon, do we need to go back to the other one and modify that other bullet, or will that be okay to do without another motion and vote?
Do we have a motion to adjust the Casevi PA similarly to Lyfgenia?
I'll also move. Thank you.
Thank you, Dr. Hoffman.
I second.
Thank you, Dr. Siegfried. All in favor for that?
Aye.
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 Thank you. Any opposed? Motion passed to modify Casevi similarly to Lyfgenia on the criteria for the HLA mass allogenic stem cell transplant. Thank you.
All right. Good morning, everyone. These next two that I have are not new medications. They're also not gene therapies. They were previously on a rare disease PA, and now we are breaking them out to give them their own prior authorization form. So the first one is for Adakveo or crizanlizumab. And our criteria start with an age limit for 16 years or older per the package insert, that the medication is being prescribed by or in consultation with a hematologist specializing in the treatment of sickle cell disease, as with the past two PAs. That the medication is being used to reduce the frequency of vaso-occlusive crises associated with sickle cell disease. That the patient has had 2 or more vaso-occlusive crises in the previous 12 months. That the patient continues to experience pain episodes despite at least 4 months of therapy with a maximally tolerated dose of hydroxyurea, which, as Dr. Lulo mentioned, has been the standard of care. A maximally tolerated dose of hydroxyurea, if tolerated, will continue to be used in combination with Adakveo, and the patient has shown to be unresponsive to L-glutamine, which is another treatment option for preventing vaso-occlusive crises. What questions do you have?
So the criteria for approval is at least one. So it could be just one of these in the list. Is that?
At least one what? What do you mean?
Of the criteria.
Oh, no.
Yeah,
Thank you
that
for
seems
that.
a little bit
Yeah.
off to me.
No,
Yeah.
that should be, yes.
All, right? Yeah, okay.
Yes,
I was
here
just
we
checking.
go.
I was like, ooh, that seems
No,
off.
thank you for that. Thought we'd caught all of those. There we go. Yes, it's all criteria. Thank you.
I'm paying extra close attention this morning.
Which is admirable considering it's the week after daylight savings, so.
I just have a question about the pain episodes.
Yeah.
I've seen in the other descriptions and presentations a little bit more narrative following the word pain, that it indicates something about the intensity, like, requiring medical therapy or something that, we're inferring that we all know what we mean by experience pain episodes.
I can clarify that and
I mean, we know
define
what
it as
the
vaso-occlusive crises, if that makes more sense.
it's the
Because
next
that's
one.
really what,
Yeah.
right,
Yeah.
but I can replace pain episodes with vaso-occlusive crises, which would make more sense for this medication, or be more specific. Acute pain
I mean,
episodes.
if that's what we're talking about, I mean, there could be other vaso-occlusive events that are, it may or may not have pain, but then we have reauth criteria that are really restricted to pain. So I was wondering if that's, that's the only criterion that we're going to include for reauth, or what if they're having vaso-occlusive crises that, I mean, they're almost always going to be painful, I realize, but they may not be on occasion, right? They might have other vaso-occlusive symptoms of concern. So I don't know if we wanted to just put something in the reauth criteria that broadens it a little bit. VOCs or VOEs or something, if we mean that.
Okay. Do we have any recommendations on changing language besides replacing pain episodes with vaso-occlusive crises?
If not, do we have a motion?
I'll move to approve as amended.
Thank you, Dr. Hoffman. Do we have a second?
Second.
Thank you, Dr. Smith. All in favor?
Aye.
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 Thank you. Any opposed? All right. Motion passed for this criteria as amended. With respect for everyone, Tom, we won't have time to go for under the criteria, prior authorization criteria. We can move that to the next meeting. It's almost 8:30. So with that, the next meeting will be April 11th. We will review on short-acting beta-2 agonist utilization. Do I have a motion to adjourn?
So moved.
Thank you, Dr. Smith. Do we have a second?
Second.
Thank you. All in favor?
Aye.
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 Alrighty. Motion passed. Thank you very much for everyone to coming to the DUR today. See you all next month.
Thank you,
Thank
everybody.
you.
You.
Aye.
Thanks. Bye-bye.
Have a good day.